welcome once again. If you'd like to interact in the chat box, you're able to do that throughout, but we'll go ahead and get started. Thanks for joining once again. We are focusing today on a new RFP toolkit and template to help improve correctional health care and outcomes. So before we get started today, a couple of tech tips and guidelines. Once again, you'll be able to use the chat box to interact. Also, please use the Q&A pod to send any questions for our presenters. We'll be able to monitor that throughout, and we'll get to as many questions as we have time for, either throughout or at the end of the presentation. So please feel free to send them. And we are recording today. The recording will be posted to the toolkit website, and we'll share all the information about how to access that. So we will be able to send it out following the event today. Also, if you would like to access closed captions, those are available. So you'll see instructions on the screen here about how to set that up and select the language that you like. So for today's agenda, we are going to have some opening remarks from the field in just a moment, and then you'll hear from the rest of our team that has been involved in the creation and development of the RFP toolkit and template, which is a 3-year culmination of this project. We're very excited about it. We'll also share some more information about kind of correctional health care more broadly, and why this was an issue that we all decided to focus on, and why the need was there to create this resource. We'll hear in more depth about the project and the history of it to get to this point today, and also have some demonstration of the resources, what they look like, how to interact with them and use them, really regardless of where you come from in this process. We'll also share a little bit about what's next from our perspective and where we see these resources going ideally, and then we'll have, again, plenty of time for Q&A, so please keep those questions coming in the Q&A pod. So first, I am going to hand this over to Michelle Deitch, who will give some opening remarks and has been really instrumental in the development of this toolkit as well, and providing review and very helpful feedback. And so we are thrilled to have her today and kick this off. So Michelle, I'll hand it over to you.
Great, thank you so much. Hi, everyone. My name is Michelle Deitch. I'm the director of the Prison and Jail Innovation Lab at the University of Texas. It's my honor and pleasure to welcome you to this webinar on contracting for correctional healthcare services and how to write an effective RFP for those services. Well, despite the unearned credit I was just given, I was not involved in the writing of the RFP toolkit that you're going to be hearing about today, but I did have the good fortune to be able to preview it and provide some feedback to the authors. And I can tell you that it's truly an impressive and sorely needed resource for anyone working in the corrections field with any responsibility at all for overseeing the provision of healthcare. In fact, I think it's a must-read and a must-use document. No agency should even think about navigating a new healthcare contract without taking account of the detailed information in this toolkit. You're shortly going to be hearing from the authors of the toolkit, so I don't want to preempt their self-introductions or their explanations for why they wrote it. But you can be assured that the authors, a self-described ragtag group of experts who saw a gap in the field and decided to fill it with this publication, they are very well equipped to provide guidance on medical, mental health, legal, and contracting issues. As someone who's been working to address problematic conditions of confinement for almost 40 years, I can tell you that there is no issue that generates more complaints or more lawsuits from people who are incarcerated than poor health care. Countless deaths in custody can also be attributed to inadequate health care. Yet people in prison and jail are constitutionally entitled to medical care to address their serious medical needs. So how can corrections agencies reduce the gap between the care that should be provided and what's actually happening? And how can legislatures and county commissioners avoid the massive cost of lawsuits in this area? One key lies in ensuring that when agencies contract for medical services, they demand that certain detailed requirements be met. And that's where this publication comes in. It lets correctional agencies know what details have to be in an RFP so they can ensure that they're getting quality healthcare services that meet constitutional requirements, best practices, and community standards. Effective oversight of contracted healthcare begins with a well-drafted RFP. And in this webinar, you're going to learn what such an RFP should look like. If agencies utilize this guidance, it will really improve the quality of care provided to people in custody. Without further ado, I'm now going to hand things back to the team to kick off the discussion, and I very much look forward to hearing their remarks today.
Thanks very much, Michelle. We appreciate that as someone that's very intimately acquainted with these issues, and thanks so much for being part of it. So now we're going to introduce the rest of our team that has been involved in this 3-year effort to get to this point today. And I will kick it off with my colleagues at Policy Research, Reggie and Lisa.
Hi, everybody. I'm Regina Herder, or Reggie, and it really is my pleasure. It's hard to believe it's been 3 years when Dr. Stern and myself were on a webinar with another company and talking about RFPs, and we got together afterwards and both knew that there was this dream of trying to really provide the field with better information about how to think about correctional healthcare. I'm always reminded that correctional healthcare, especially in a jail, is not an island, and yet that's how we tend to treat it, as if it's something different than what we should have as standards within our general community. So very happy to be with you today and really appreciate all of the folks who weighed in on this over the last 3 years. So Lisa?
Thanks, Reggie. Thank you, Ashley. I'm Lisa May, and I am a senior project associate with PRA. I am based right outside of Atlanta, and it's been just a pleasure to work with all of the dedicated professionals that you will be hearing from today. It's been a wonderful experience. We all know, at least this group, and you will as well after this webinar, seeing how crucial it is for jail contracts to establish a clear framework for not only service delivery, but also ensuring that that contract effectively addresses the needs of the facility, its persons who are in custody, but also promoting basic transparency and accountability in the bidding process. A well-crafted RFP can help mitigate risks by clearly defining the responsibilities, timelines, performance standards, which all help to prevent any disputes, delays, and the provision of care. So welcome again, and thank you so much for tuning in, and I'll hand it back over to you, Ashley.
Thanks, Lisa, Reggie. Mark, David, want to introduce yourselves?
Reggie, go for it.
Mark, I think you're up. Go ahead.
Okay. Mark Stern, I'm a correctional physician, and I'll be talking a little bit later, but Michelle, thank you so much for joining us. And as people don't know, you're actually at Oxford University tonight. So that's took a lot of extra effort to come. So thank you. David?
Nice to meet you all. I'm David Sinkman. I'm a civil rights attorney with a practice that focuses on people in the correctional systems and the treatment that they receive. I'm formerly of the Department of Justice, where I worked on expanding opioid addiction treatment in the criminal justice and health systems. And I was also involved in the New Orleans police and prison consent decrees. And this is a powerful tool that can empower local municipalities, towns, cities, and states to ensure that people in their jails and prisons are protected and receive the type of medical care that they're constitutionally entitled to. And it's a tool that hopefully will put me out of business in the sense that it will prevent litigation and also prevent federal and possibly state investigations. So it's something that we're really excited about, and we hope that you all use it.
Thanks, everyone. Barry Zach is our 6th member of the Ragtag Group and is rounding that out. He's the CEO of Corrections and Health at the Bridging Group. We all, as you see, bring a little bit of a different slant and expertise to this project, and it has been a very organic project in all of us, as has been said already, wanting to focus on this because of the need that we've seen across our different subject matter areas, and originally started, without a lot of direction, without even funding at the start, and was very much a passion project for all of us. So at Policy Research, our crux point is the individuals with criminal justice system involvement or those who are at risk of involvement. And then in particular, for our team, folks with behavioral health needs, mental illness, substance use, as well as the physical health, often co-occurring needs. So that's a lot of the different pieces of expertise that we bring to this work. All right, we would love to get a better idea of all of you and who is in the virtual room today. So I'm going to open a poll. If folks can just take a few minutes, this is a 2-question poll, and it will give us, again, a good idea of the roles and the expertise that you're coming from, and then also, why the interest in this topic, why you think it's important. So if you could take a moment and fill out that poll, we'll see who is here today. So our numbers are moving. Again, if you have questions throughout the presentation, please use that the Q&A pod, which you might see at the bottom of your toolbar in the Zoom room. That's where it shows for me, but it should be a Q&A with a question mark in the icon. And then there might be some that we'll answer just via chat in that box, and otherwise we'll answer them verbally during the presentation. So please send all your questions in. All right, I think about 3/4 of the group, and it's growing, has answered. We've got about 127 folks on the call this morning or today, so you have an idea. We overwhelmingly have jail staff represented in the room, about 21% of folks, although we have a pretty good spread across all of the roles that we've listed here. So a lot of other as well, but as far as the specific roles, we've got jail staff, less so with prison staff, a little bit of juvenile detention. We have a lot of community providers, some correctional healthcare vendors, a little bit of procurement folks that focus on that piece, and then some non-correctional government, correctional oversight. So that's about the breakdown of who we have, kind of in the order that I've been relaying them. And then as far as interest in the topic, certainly that first option, providing better care for folks who are incarcerated, is we've got about 74% responding that that's their priority. About 39% of folks say improving healthcare providers' accountability to the facility. So we'll speak to that piece in particular around accountability. About 15% of folks have expressed dissatisfaction with the current healthcare model or vendor. And the cost efficiency is also growing. So obtaining higher value and cost efficiencies across the correctional healthcare is about 30% of folks. Thank you. That is helpful, and it will also inform some of where we go from here and the future work we do with this project. So I'm going to close poll. Thanks, folks, for responding. And we will move on. So to set the stage sort of broadly before we get into the actual work of the toolkit and the project itself, is just this issue of correctional healthcare and why we come to this work. Number one, we're talking about a lot of people, right? So we know that despite jail reductions and prison reductions in a lot of places during COVID, we have a lot of people that are cycling through and recycling through, in many cases, jails and prisons across the US. We also know that healthcare is a constitutionally mandated right for this population, and that is a very complex issue. So we are talking about a lot of overlapping, often co-occurring needs in addition to just physical health. Certainly our expertise and our work around substance use disorders, mental health, mental illness, really illuminate that, as well as other sorts of needs that are often underrepresented, like brain injury and disabilities and other sorts of needs that we find at higher levels in this population. We also know a lot about the effects of corrections and of incarceration on physical health, on lifespan, and even flowing over onto family members of folks who have been incarcerated. So you'll see some statistics linked in the slides here, which will also be available to you. But just a high need population, a challenging population to serve. And obviously a lot of that is due to the setting in which healthcare is provided. We also know that, as I just mentioned, there are a lot of folks that are recycling through the criminal justice system, jails and prisons, and in many cases because of unmet needs or because of charges that are perhaps related to those unmet needs. So again, just high needs, very complex. And I'm sure many of you on the call are familiar with headlines and news reports that are really highlighting these issues and the unmet needs that we've seen across the country. So I'm going to turn it over to Dr. Stern now, who will talk a little bit more about the project itself and how we got here. Mark.
Thanks, Ashley. So this project is, or what you're going to have, is an RFP, by the way, request for proposal. Everybody calls it something different. We've chosen the term RFP. And the toolkit is, that we'll also share in a moment. Maybe toolkit isn't the right word. It's a kind of an explanation of what you should be thinking about before you enter into even start the RFP process and how to go about it. And at the center of the toolkit is an actual model RFP that also we will walk you around today. So the impetus for this came from our recognition, as Michelle had said, and Ashley and Lisa added to, of bad outcomes. I am not a big fan of privatization of healthcare in jails and prisons, and none of us are, but it's a reality. More than half the jails and prisons around the country have some form of privatization of their healthcare. And so whether we like it or not, we need to recognize that. And from the work that we do, that I do, we see a lot of bad outcomes, people dying or other health-related bad outcomes. And as we thought about that, as we looked at some of those outcomes, as we do in our regular work, we saw that where there's a private vendor, the bad outcome happened because the vendor didn't do something they were supposed to do. And we'd work backwards and look at the contract with that vendor, and the contract didn't ask them to do it. So they didn't do it, and there was a bad outcome. And even going further upstream, the contract is pretty much a reincarnation of the RFP. You have to tell people what you want them to do, then what you're looking for them to do in the RFP. The contract says, here's what we actually want you to do, and then the outcomes. So all of this really is driven by, as we've said, improving outcomes via the RFP. And so then we'd asked ourselves, why are RFPs inadequate? And there's a couple of explanations. One is that because jail and prison administrators are not healthcare experts, you need that expertise to write a good RFP. They don't have it. So what I've seen a lot of, especially in county jails, happening is that the jail administrator goes over to the county next door and says, hey, can I use your RFP? Which came from another county next door, and no one actually along that chain had the expertise to write a good RFP. The second problem is that in a lot of jurisdictions, it's a procurement officer who is responsible for helping to or writing all of the RFP. And procurement folks are specialists in procurement, but not necessarily in content. So on Monday, they may be writing an RFP for a sewer system, on Tuesday for parking meters, and on Wednesday for healthcare and jails. And we can't expect them to have that content expertise. So again, that was our impetus, along with, finally, that we didn't just want to reincarnate existing RFPs. We wanted to, through this RFP process, move the needle to improve the quality of healthcare, not just because people have left things out of their contracts, but for innovative frontline concepts of how you should be conducting healthcare in a jail or prison. And we'll get into that. So as Reggie said, about 3 years ago, we all met and were equally passionate about it, set out to do this project. It is just coming to fruition, and we had a lot of help and input and support, moral and otherwise. And Ashley, if you'd kind of share that with the audience. This is just a smattering of some of the groups who, like I said, various amounts of different types of input, feedback, just support and willingness to share this throughout their networks. We've been working on this for about 3 years. We had no funding at the beginning, and David helped us secure some funding towards the middle. What we're going to do in the next, what remains in time, is we're going to walk through the RFP template toolkit itself. Ashley will, as Ashley is showing you, these are the various major topics in the toolkit. I'm going to talk about some of those in a moment, and then we'll demonstrate the RFP itself. So, and we're good for the first slides, Ashley. So some of the, I'm not going to go through the entire toolkit, but I do want to highlight some things that we think are innovative and really important to think about before you even sit down to write the contract. That's why they're in the toolkit. So one of the things, for example, that we talk about is, should you outsource at all? What are the advantages and disadvantages? What are the alternatives to outsourcing? Or is it something that you should provide in-house with staff who are employees of your county or city or state? Another thing that we touch on in the toolkit is the issue of policies and procedures. So most places that contract for healthcare, they'll have a vendor come in with the vendor's policies and procedures. And when the contract is over and it gets rebid, the new vendor will come in with their policies and procedures. The problem with that process is that policies and procedures should capture an organization's history and history with bad outcomes. For example, let's say your policy and procedure manual, and this is from a real example, doesn't address how nurses are supposed to conduct medication line for administering insulin. And so there was a jail that had a problem where the nurse was drawing up the insulin, drew up the wrong insulin, gave it to the patient, and there was a bad outcome. And as a result of that, the jail figured, found a root cause and a solution. And among the solutions was to change their policy such that nurses, whenever they're drawing up insulin, they're supposed to draw it up, show the bottle to the patient as confirmation, because most patients know what they're supposed to be taking, and then go ahead and give the injection. Well, imagine that jail has that change in their policy, and then a new vendor comes in and that change is lost, and so they're destined to make the same error again in the future. And so one of the things that we recommend organizations to do is say, instead of having a vendor bring their policies and procedures, that in anticipation of the RFP, you construct your own set of policies. And those are the policies that stay with you as the organization, as a facility, from vendor to vendor. There's always room for modification. Vendor may have some things that they want to add to it or change, but it's your policies that the staff becomes familiar with. And when there's a turnover of vendor, as we know, most staff transition from one vendor to the other. They already know the policies and procedures, and that's important for safety. Another topic that we talk about in the RFP in the toolkit is the issue of lumping versus splitting contracts. Should you have a contract just for medical and another one for mental health and another one for substance use disorder, or should you have them all in one package? So that's a conversation. We also, another topic is recommend involving experts in the development of your RFP. Our expertise went into this template, but you have local needs and local conditions that you need to address, and it's really valuable to have a content expert, a correctional nurse or doctor who helps you with your RFP development. We also talk in the toolkit about how to make your RFP as visible as possible, because that's sometimes a problem that you guys may have experienced where you issue an RFP and nobody answers. So we have some ideas in there about how to deal with that. Another topic we talk about is what we affectionately call the dog and pony show. When you've received responses to your RFP and you've selected 2 or 3 or 4 vendors who you're especially interested in, and you ask them to come to the facility so that they can see what the facility looks like and ask questions, and at the same time they can present to you some more specifics about their proposal. And so we have some, I think, really good suggestions about how to conduct that process. And finally, one thing I'll mention that's in the toolkit is how do you migrate the RFP to a contract? Because as we've all said a little bit earlier, that RFP is pretty much the foundation for what's going to go in the contract. But there's always some room for negotiation, and we have some, I hope, really helpful suggestions in how to do that. So I am going to transition from that. I just look to my team members if anything else somebody would like to contribute about the toolkit before we get into the template itself.
Yes, absolutely, Mark. So before we transition, we have a question from Joshua, and he's asking that if you could please comment on the importance of articulating a strong health standard of care and defined in an RFP, especially if there is not a strong standard of care in legislation, regulation, or policy. You're on mute.
Thanks, Joshua. You've captured pretty much what this was all about. Because of what you said, that it's sometimes hard to find that standard of care. That's what we were trying to write, is a document that if you followed this, you would be following the standard of care. We don't actually label things as a standard of care here and there, but by implication, that's what this document is about. What we tried to construct is something that you would be able to pull off the shelf. It's in a Word document. It allows you to modify it. And what I want to talk about for the next few minutes before we show it to you, just like I did for the toolkit, is what are some of the innovative, move the needle kinds of things that are in the template. So first of all, there's an extensive section in there about the kinds of information that you should provide to the vendor in the RFP. One of the problems that we've heard from vendors is when they look at RFPs, the facility doesn't describe enough about itself, about its healthcare operation, and mostly about the exposure, the risks, the costs that the vendor would be assuming if they took on the contract. Without that rich information, a vendor is going to have trouble formulating a really good bid. They're going to have to guess at things, and as we've unfortunately seen around the country, if that guess is wrong, one of 2 things happens. Either they overprice the RFP and the contract, in which case the jurisdiction loses because you're paying more than you need to, or they underestimate the costs that the vendor that they're going to incur as the vendor. And then what happens is they get a certain way in, and they'll come back to you and say, as the facility, either we need more money, which your county or state legislature hadn't counted on, or they leave, which is dangerous for patient care and disruptive. So you're going to see a list of a lot of things that we recommend that you inform potential vendors about so that they can make an informed and intelligent bid. It looks like a lot of information, but it helps assure a good bids on their part. Another thing in the RFP template that is different from most contracts right now that we encourage you to look at is the way you ask the vendors to propose staffing. Almost every RFP that our team has looked at is very prescriptive in how they ask the vendor to respond and perform with regard to staffing. What I mean is that you'll see these long lists in RFPs that say or in a contract that says, we want you to have X number of nurse FTE and X number of physician FTE, and they have to be here this hours in these buildings, etc. And while we offer you the option of using that model, we also offer a different model, which instead of being structure-based, structure being the type and number of people, it's performance-based. It largely says to the vendor, here's the things we want you to do. Here's how we want you to perform. Here's the outcomes that we're looking for. And there may be a couple of specific things in terms of staffing that we require. For example, we want an RN in the booking area of a jail 24/7. But beyond that, we're not going to specify the staff, the FTE and the type of staff. We're going to leave that up to you. And you decide how many, let us know how much and what kinds of staff you want. That's a performance based. But what we are going to measure, vendor, is we're going to measure your performance. Here's the things we want you to accomplish, and you bring in the number of staff you need to accomplish that, but you better accomplish that. So that's a concept that is very central to the RFP template that you'll see. And we think it's an important one that moves the needle in a different direction. Another topic is electronic health records. And it's very similar to policies and procedures. What we find is that every vendor brings their own electronic health record, or one that it may not be their own, but it may be one that they prefer using. And that introduces a potential for error, because the staff, who, like I said before, tend to be the same staff from one contract to the next, one vendor to the next. They get used to using one electronic health record. Now you're asking them to learn a new one. The second problem is that the migration of rich data from the previous vendor rarely gets into the new vendor's electronic health record in a usable way, if it even gets in there. Typically what happens is that what the old vendor will do is take everybody's medical record and put it into a PDF for that patient, and that PDF gets imported into the next vendor's electronic health record, except, as you guys can imagine, a several hundred or thousand page PDF is not very useful. On the other hand, if you subscribe to your own or buy your own electronic health record, that information continues from staff member to staff member, from vendor to vendor, and we believe is a much safer and wiser way to operate. But that means that you need to get your own RFP. Another major move of the needle in this RFP model template is moving away from the way that we provide care in so many institutions, which is it's nurse-led as opposed to practitioner-led. And we're asking nurses to do something that they are either not legally qualified to do or really not qualified based on their training. We ask them to see patients with de novo problems. These are patients who you all know are the sickest patients in our communities. They have the most carry the most burden of disease, whether not just mental health and substance use, but chronic medical problems and communicable diseases. And so here's a really sick population who comes in with a new complaint, a new symptom. And we believe that evaluation of that symptom requires the highest level of clinical acumen, which would be a physician, nurse practitioner, physician assistant, as opposed to a nurse. On the other hand, RNs and LPNs play a very key role in healthcare and in correctional healthcare, and the RFP template enumerates that. Another topic that is very important to us that is described in the RFP template is treatment for opiate use disorder. And David brought a lot of his expertise, legal expertise, into this RFP, and we know that many of the bad outcomes that we've seen are related to opiate use disorder and other substances, and the model provisions that we put in the RFP should help you to avoid those problems. Another topic in the RFP is helping you navigate the 1115 waiver process. For those of you who are not familiar with it, Medicaid has allowed states to apply for and be able to implement demonstration projects that wherein Medicaid will pay for some care in that last either 30, 60, or 90 days prior to release from your institution. I think at this point, close to half the states in the union are pursuing 1115 waivers, and we have verbiage in there that helps with you incorporating 1115 into your RFP. Another topic we talk about is no-shows. and how to deal with patients no showing to either getting their medication or no showing to appointments in the clinic. And that's another source of liability where because patients will, if they don't come to an appointment and then a problem develops and they have a bad outcome and they sue. And so we link the quality of care and liability to making sure that you always know where patients are. Hopefully all institutions do. But in addition to that, dealing with no-shows in a way that's really effective. Another topic that we address is having a very, very clear problem list in the medical record. It is such a valuable tool for clinicians, and it seems to be an area where we see some liability and bad outcomes because the clinician taking care of the patient didn't realize that they have a history of X or Y, and because the problem list was not kept up to date and wasn't clear, or was populated with tens of things that have little little value. We incorporate also in the RFP template a list of key performance indicators that are subject to penalties or liquidated damages if the vendor fails to perform. We're going to look at that in a few moments. We also, in the RFP model, try to encourage you to move away from the typical tool for selecting a vendor. And the typical tool is that you'll get a committee together and they'll assign a certain number of point value to different aspects of the RFP process, of the RFP or contract process. In other words, they may say, well, you can give up to 10 points, the person who's on this selection committee, 10 points for pricing, and another up to 10 points for the vendor's track record in other facilities, etc. And while that sounds logical and reasonable, we see that that doesn't work very well because each of these components of a contract or an RFP don't have equal weight. The cost of a contract is not the same, doesn't have the same value as the vendor's history with other jails or the same value as what's in their proposal. And so instead, what we encourage folks to do is to have your committee get together and choose a vendor by discussion and consensus, or by having each of the committee members give a global score of this is the vendor who we think as a package presents the best for our city, state, or county. And related to that, we recommend not bothering to ask vendors to produce letters of reference from previous places, because as we know, whether we're talking about healthcare vendors or whether you're talking about employees, if somebody that you're considering hiring, you're only going to go to the places as an employee or as a vendor, you're going to go to the places you've worked with before and said, hey, give us a letter of recommendation. But we know ahead of time these are places that we're satisfied with either us as an employee or a vendor with the care. But instead, what we encourage you to do is ask the vendor to list all the places where they have provided healthcare, and then you decide which places you think you want to get in touch with and have a phone conversation as opposed to having them fill out a letter or a form. We think you get a much better product. So let me take that. That's kind of a quick highlight of some of the things that we think are particularly important, innovative, moving the needle. Before we get into actually walking through the document, I'm going to stop and see, Lisa, if there are any questions from the questions or anybody else has anything to add.
Yes, absolutely. We have several questions for you. So going back to staffing patterns, Adam has asked that without specifying minimum staffing requirements in the RFP, how can we compare apples to apples? Staffing is a huge driver of costs, and any vendor can say that they can accomplish the goals with less staff. Wouldn't that be an easy way to show a lower price proposal, even though it may not be sufficient in reality?
Yeah. So that's a really good question, and something that I guess I'll even say struggled with as we developed this RFP template. And the answer, there's a few parts of the answer. One is that there's nothing that prevents you from asking the vendor to submit as part of their proposal how they're going to staff. And that allows you to compare from vendor to vendor how they're going to staff. The second part of the answer is that's the importance of performance outcomes, of saying to them, this is what we want you to accomplish, and this is what we're going to measure you on, and there are going to be penalties if you don't do it. So even in today's world, with today's RFPs that people are putting out on the street, a vendor can stretch the truth there too. They can say, we're going to do all this and we're going to do a wonderful job of it, and then they don't perform. So I think the risk that you're describing exists even now. I think we come up with a solution that results in fewer risks. Reggie, is this? Do you want to say anything more about that?
Yeah, thank you, Mark. So another part of our discussion with this, we addressed it some in the toolkit itself, and not just in the template, is that so sometimes people, as Mark is saying, will in their response say, yes, we can do all these things, and we'll have the staffing pattern, but fairly quickly, sometimes just months after the RFP has actually been bid, and there's been a decision and the services are contracted for, it's not uncommon to have folks, the vendor, say that we need to have an amendment to the contract. And in that amendment, what we often see is going to be a change in the staffing pattern. So even though you put out a certain kind of request for staff, a lot of times that gets changed. And that amendment process itself is an area that we talk about, but also really want to encourage folks to really be mindful of, especially when it comes to staffing. So that was part of our discussion and us landing on how we present the staffing work, because we know that oftentimes it's going to be bid out. And if you're really looking at performance-based, then you can kind of manage that a little bit differently, even in those discussions around a contract amendment process.
Thanks, Reggie. Sorry, Dr. Stern.
And another thing, a reason to go for performance-based instead of structure-based is two reasons, actually. One is that we see facilities spending a lot of time and money monitoring that, micromanaging and monitoring those personnel issues. In other words, saying, well, you were supposed to have 1.5 nurses in this unit on this day, but you only had 1.2, and we're going to dock you. We're going to dock you. So you put a lot of extra time and money into that, as opposed to measuring just the outcome. The other problem is nimbleness, as Reggie was referring to indirectly. And what I mean by that is conditions change at a jail or prison, and it may make more sense to move a staff member from one place to another, or change the nature of their work. In other words, change out an LPN for an RN, or remove a position. And what we see happening is, when making those changes, as Reggie alluded to, requires a change in the contract. And so you spend hours and hours and cost of lawyers' times, et cetera, to make an amendment to the contract, where if it's just performance-based, the vendor does it like that from one moment to the next, which saves them money. It saves you money. It gets the change effectuated almost immediately.
So sticking with the staffing patterns that we've been discussing, Daniel has asked what provision should be made in the event that custody is short-staffed and can't support the provision of healthcare.
Yeah, that's a good question. And I don't know that we really deal with that in the RFP. I think that is, would be something more, I don't know that it's going to make a difference in which vendor you hire. Let's put it that way. I think what that's going to inform is the policies and procedures for your facility of what do we do in an emergency lockdown, for example, where people can't move, or the situation that you described, Daniel, where you're understaffed. I think that would be something you address, like I said, in policies. Anybody else in the group have a take on that? All right, Lisa?
Yes, so next couple of questions pertain to the scoring. So Benjamin has commented that challenge with discussion-based decision rather than scoring is that it is more likely to be challenged as subjective by parties not awarded the contract. Oftentimes, such matters are determined by public bid laws.
Right. So that's a good point, and also something that we spend a lot of time talking about for specifically the reason that you bring up. It's a good opportunity to tell you something that we do have in the toolkit, which is these are suggestions from us. You're ultimately going through a legal process. You need to follow your local rules and regulations, the local laws, and you should have a county or state attorney, whoever your counselor is, involved in this. And so if this is if what we propose is in violation of what your rules and laws say, well, definitely you should do what's required. However, what we did to prevent what you're talking about, we did two things. Number one is we discuss in the RFP template, in the model, exactly what the process is so that the vendors know up front. It's not a loosey-goosey, hey, we just got together and we had some coffee and we're defining. It is a very defined method of selection. It's just not based on points. It's based on other objective things. In the RFP, in the model, it says, it enumerates, here are all the factors that our committee is going to consider. Here's the process, how we're going to deliberate, and that's how we come up with our solution. David, any other legal thoughts on Daniel's question?
No, I think you hit the main points, which is that you have to, this is a general RFP with applicability across the country. It's not unique to any set location. So any RFP from that location has to comply with local rules and regulations.
Lisa? Thanks, David.
So Amy asks, why do you recommend doing consensus funding decisions versus scoring? What are the pros and cons of that approach?
So Amy, I'm assuming this sounds like, again, the same issue of how does the committee make its decision. And I think what we've just talked about is the answer to that, which is that I think you end up with a much more robust decision, because it's not based, you're not forced into a corner. So for example, let's say that pricing is assigned a certain point value in the committee's decision, and quality of care is assigned a certain point value. You could imagine a very upside down world, and we see this happen, where the price is very low and they get a whole lot of points for that, but the quality was very poor, and depending on how you construct your point value, you could end up with having to take the vendor who provides the worst care, and vice versa. You might have a vendor who's doing a great job with quality of care, and the cost is astronomical, and you're now stuck with your point value system. And you might think that you could adjust the point values before entering into this, but what we're telling you from our expertise is it's impossible to do, because it's not a linear process. You can't say that X amount of this decision is solely based on cost, and X amount is solely based on their track record, and X amount based on the quality of the care. They all interact with each other, and the only way we could come up with taking all of those things into consideration the way they should be considered is with a global score.
Mark, if I can, so in the beginning of before actually writing the RFP, and you'll find in the toolkit that we spend time talking about the importance of you understanding why do you want to do why are you doing a new RFP? Is it because your current RFP is up, or is it because there's been challenges with the current delivery of services? Is it a combination of that, or other kinds of factors? And in that particular process, it's incredibly important to really think about, so what's been working in your current process? Are the staff delivering? Do you have consistency? Did you have a lot of changes from prior contracted staffing to new staffing? Or in scoring it, were there things that that you realize that maybe you had a very rigid kind of point kind of scoring. And when you think about it now, that wasn't necessarily the most important. What scored the highest may not be the most important. And as Dr. Stern was saying before, part of it is how even those points are set up may not actually be really getting you to the best outcomes in an RFP or delivery of your healthcare. So as Dr. Stern is saying, is that these are really thinking about what do you know about your current system, what really works for you, and then thinking from there about what is it that might need to change. And so you are absolutely welcome to do a point type of system on your RFP, but without really thinking and having the discussion, if you only did the points, we don't think you're going to have the best outcomes with that.
You, Reggie. All right, shifting gears to performance-based measurements. Dr. Stern, Stephanie is presenting that if you're looking at performance-based versus measurement-based oversight, how often should that be reviewed? Monthly, quarterly? Often changes need to be made quickly.
That's a really great question, and I think we do address it in the both the toolkit and in the RFP. There is no perfect answer to that. In the KPIs, I think we propose doing it once a quarter, but frankly, I think monitoring can and maybe should be a fluid kind of thing. In other words, you measure things that are going well, you may decide to measure a little bit less often. Things that are not going well, measure more often. But we do make some suggestions on periodicity in the document, and I think largely in terms when you think about the key performance indicators and liquidated damages, I think we recommend doing it once a quarter. It's a reasonable interval. Sorry.
That's it for now for the questions. Thank you very much.
All righty. Well, Ashley, how about we take people for a drive around the RFP?
Good.
So this is the baby. It is a Word document, and we did that on purpose so that it's something that you can manipulate, something that you can add to, change, do whatever you want with it. There is some introductory material that Ashley has already removed from here, but that you will see that has some instructions. And so the format that we use for this document, for this Word document, is that anything that you need to fill in is going to be in brackets. So at the very top of the document here, you can go a little bit higher, Ashley. So it says the first line says state, county, city, regional, whatever. You're going to identify yourself. That's in brackets. So if you are Yakima County Jail in Washington State, you're going to that's what you're going to put in there. So this would end up being the first page of your document. The other convention that we have is that we have a lot of instructions and or information in the Word document that are only meant for your consumption. So for example, Ashley is scrolling down to, at the bottom of the page, this key events timeline. And this is an instruction to you about how to go about constructing that timeline. And it's meant to be removed ultimately from the document because it's just information from us to you. And so that information is highlighted in this, what I'll have to admit is an ugly color brown, but it is functional. And so you would go in when you're doing this RFP, you'd read that, and then you would, as Ashley is doing right now, you would delete it, and we'd be left with the actual wording of the RFP that you're gonna put on the street. Along those lines, I'm going to show you how that process works in a little bit more detail. Ashley is going to fast forward down to section 8, which is kind of the meat of the document that has the actual scope of services. And just as an example, we're going to show you something in section 8.2, which has to do with patient evaluations upon entry into your facility. So Ashley's scrolling down to that section, and in 8.22 is 8.2.2 is something about the screening process upon entry. So here up in the top of the document, you see the stuff in light brown. And the first area is RFP provision explanations. So for example, in this particular RFP provision that we're going to have below, we talk about opt-out and opt-in testing. And we imagine that many of you, unless you're clinical, don't really know what opt-out and opt-in is. So this is where we explain to you, give us a little bit of education of what is opt-out testing, what is opt-in testing, so that you have that knowledge to be able to decide what you want to do with the choices of the RFP provisions themselves. So what you would do is, once you've read this RFP provision explanation, and just delete the first 3 paragraphs, Ashley, you would just highlight that, you would delete it, and then the last part of that instruction is that, the last part of that deletable information is it's an instruction that says delete one of the following, one of the 2 provisions below, retain the first one if you operate a jail, and retain the second one if you operate a prison. So we're going to, there's the second one below. So since we're operating a prison, not a jail, we're going to delete that first provision. And just hit delete, and it's gone. And then we're going to go back up a smidge and delete that instruction because it's no longer relevant. And RFP provision is also highlighted. It's just a way of you're being able to easily navigate the draft. But we now have the RFP ready to go. At least this section, 8.2.2, we've gotten rid of the instructions, the information, background information, and this is the RFP that the provision that we would have. A little towards the middle of the page, you'll see another bracket which says, if your prison receives individuals directly from the community, as a prison, you would want to include the following. And so that bracketed information, which actually we probably, Ashley, as I'm looking at it, we're going to put in the background brown color, but anyhow, like Ashley just did, and because it's brown, it gets deleted. And since we are a prison that it takes individuals directly from the community, we're going to leave that clause in there. So we now have provision 8.2.2 ready to roll, and that's how this entire document is constructed. You remove anything that is highlighted that's meant to be background or instruction. You fill in anything that's in brackets, and you've got your RFP document. So next, we're going to fast forward to the bottom of the document, which is the key performance indicators, and I want to show you a few of those. So once again, there's some background information that explains the process. You would highlight that as it's just for your eyes, delete it, and then what's left are the actual instructions or the information about how key performance indicators are measured, how liquidated damages are calculated. All that should remain in the RFP that you put out on the street. And then we're going to scroll down to a few examples of key performance indicators and their related liquidated damages. You can see their different sections of it, and we're going to land on access to care. And so, for example, here we've highlighted in the red box two performance indicators to show you. The first one, AC4, says patients discharged from suicide watch are evaluated by a master's level master's level or higher licensed clinician between the 2nd and 4th day after discharge, and between the 12th and 16th day after discharge from suicide watch. And so what we expect, what we offered as a threshold value in the second column, is 100% performance. And I want to go into that for a moment to mention 2 things. First of all of this is adjustable. We've said 100%. You may sit down and say, well, we want to use 95% or 98% or 50. You can put in there whatever you want. We're suggesting 100%. The other comment that I want to make about that is that one of the drawbacks of performance indicators that we've seen that are out in the community, in the prison jail community, is that they set the bar pretty low. They'll set the bar sometimes at 80, 85, or even 90%. And those values may be okay, but it depends very much on what you're measuring. So for AC4 that we have here highlighted, we believe that there is no room for error, that this is so important for patient safety that you, the vendor, should get it right every time. And so that's why we set it at 100%. Whereas, as you can see in the previous KPIs above the red box, there are times when we think a lower performance is acceptable. So it varies by content. And then in the third column, you'll see what the liquidated damage is. And so that, in this particular case, as the instructions would explain, it would say that at every quarter, we're going to measure this. And for every percentage point less than 100% that you're performing at, there's going to be a $500 liquidated damage. So if you're performing at 98% instead of 100%, that would be 2%. That would mean 2 times 500 or $1,000 liquidated damage. And then the second one that we have highlighted in the red box here, which is AC5, individuals identified as in need of supports and accommodations in compliance with the Americans with Disability Act, receive them within 48 hours of booking into the facility. Here's one where, as I mentioned a moment ago, we want everybody to perform well, but 90% is pretty good. It's unlikely that somebody's going to die as a result of having their accommodation in 72 hours instead of 48 hours. Again, not unimportant, but in terms of patient safety, it may not have been quite as important as the one above it. So we set it at 90%, and in this particular case, we assign a value of $1,000 for every percentage point under 90. You may say that you think the one above it, Suicide Watch, should have had a higher value, $500, higher than $500, and this one have a lower value. That's fine. You just make it work for what you think is important to your facility. So we're going to lastly scroll to another section here and show you a couple more KPIs. So this is the two that we have in the red box. The first one is all deaths are unavoidable. Said in not so many negatives, that if somebody dies of natural causes, because let's say they had cancer, everybody expected it, you took good care of them, you diagnosed the cancer on time, gave them the clinically appropriate treatment, that's fine. But if any of those elements are missing, that death was avoidable. And you should be operating 100%. Nobody should die because of something that you as the vendor did wrong. And that's why that's set at 100%. And the penalty here is not based on percentage, but it's based on events. So a $10,000 liquidated damage for every death that you determine was avoidable. Below that, the last one there is patients with a diagnosis for hypertension who've been in the facility for more than 3 months have a blood pressure at or above or below the target. And you may be surprised that we set this low, but it really does make sense, because this is not something that's totally under the control of the vendor. There's patient decision making that's part of that too. A patient could just say, I want to have my Chunky Monkey ice cream every night, even though I have diabetes. And so you could have the best vendor in the world. Their hemoglobin A1C, their blood sugar control is not going to be very good. But we believe that certainly some of their diabetes control is under the control of the vendor. And so that 80% says that. In a way, it almost says that we think 80% of their diabetic control is in your hands, and 20% is in the patient's hands, and nothing you can do anything about. So therefore, as long as you can perform at the 80% level or better, you're doing okay. If you can get higher, we love it. And for every percentage point below it, in that quarter, you'd be fined $500. So I think, Ashley, that's everything that we have to highlight. Is that right? So will Lisa take more questions?
Yeah, absolutely. Staffing seems to be question of the hour for you, as well as performance standards. So going back to Dale's question, he wanted to know, how do you address staffing challenges with healthcare contractors and what they may be facing? They're currently working with direct staff and the HSA who are providing services at the correctional facility. However, the healthcare agency headquarters are making their job challenging, in which effect the performance is not being performance indicators, not being able to screen folks within 48 hours, which then imposes fees. So how do you address those staffing challenges, not only at the local level, but with headquarters?
Yeah, no, I don't think most people have any staffing challenges these days in prisons or jails, right? So that's I said tongue in cheek. Of course we do. And COVID didn't do us any favors, and we haven't fully recovered from those staffing challenges. And even before COVID, we had them. The first and most important factor in hiring enough staff is salary and benefits, is compensation package. And that's one of the things that we do address in the RFP package, and ask the vendor to describe how they're going to address that. And it does factor into the cost of the RFP. This RFP is about the way you should be providing care. It's about how do you meet the standard of care. And I suspect that if you ask a vendor to do everything that's in this RFP package, it's going to be more expensive than it was before. But that's why we get sued, because we didn't do things that we should have been doing and we had a bad outcome. We don't have a perfect answer for you, in the sense that that's why this is written in a Word document where you can pick and choose what you want to do. You may say, there's no way we're going to be able to afford some of this stuff, and we're going to remove it from a requirement for the vendor. You can do that. I would say you do that at your own risk, because if you're not asking the vendor to perform at the standard of care, then you run the risk that there are bad outcomes and you get sued. But the reality is reality. You have to deal with what you have, and you can change this document the way you need to change it. But we do, coming back to the core question, Lisa, we do talk about how to find the vendor who's most likely to pay their people enough, and make sure that they have enough staffing, and make sure that that they pay them enough and they have very few vacant positions, if any. Anybody else? No? Okay. Lisa?
Next question. Do you have time for another question? A couple more, actually.
Yeah, I think Ashley will let us know when she's pulling the curtain down.
Okay, that sounds good. This may potentially be outside of our scope of work, but how can states work with vendors to up the standard of care across counties?
I don't know if I'm being overly simplistic, but I think that's what this RFP template is about. This tells you, if you didn't, which we know a lot of jails and prisons don't know what the standard of care is, because if you're not a healthcare professional, if you're an HSA, a health services administrator, yeah, you know, but if you're a prison warden or you're a jail commander, you don't know. And that's why we produce this. So you would now know, what should you expect a vendor to do? So this document is that communication, Lisa, between the facility and the vendor. This is the standard that we want you to achieve.
Exactly. All right, Adam is asking us.
Join in on that one just for a moment.
Yeah.
Is that we also took in consideration the size of the facilities. So small jails versus medium size versus large size jails, understanding there's different challenges in more rural communities versus urban communities. So we took all that in consideration in writing this. And one of the things I think to this particular question, which is a good one, is in trying to, if the more that jails use some common standards in requesting for the provision of care, can actually help to create more of an even base across your communities, because it's very likely that you have folks in your facility, especially in county jails, that may also be persons that are detained in a different facility. And so when there's this kind of dysregulation, if you will, between the services themselves, that can be very problematic. So the more that there's some standards across expectations within a state, and then across counties and between state systems and county systems, we're hoping to actually have better outcomes, because there'll be more consistency in the expectation and the standards of care.
All right.
I think cost is it's something that was I don't want to say hanging over our heads for 3 years, but we're acutely aware of the fact that to provide clinically appropriate care costs more money than a lot of county, city, state legislatures are willing to put into correctional health care. We can't fix that. This document doesn't fix that. It just doesn't. Inadequate funding is, I would even say, even more of a root cause than an RFP and contract. You can't get something with nothing, or you get what you pay for. And if you're underfunded, you won't be able to achieve some of the things in this RFP template, and you will have likely bad outcomes. Sorry for that sobering comment.
Okay, so Adam, he is asking us, he's making the statement that states and audits are conducted by the vendor themselves in almost all cases. When evaluating performance, we would have to rely on the vendor's statistics. How do you get around this?
I guess my first answer is you don't get around it. You do have to do audits. I would disagree. Well, to a certain extent, you have to use vendors' data. I wouldn't argue with that, especially if they have an electronic health record. However, the audits themselves are your responsibility as the facility administration. To do otherwise is asking the fox to guard the hen house, to use that comparison. You have to do audits yourself. And sometimes you have to audit not only the performance, but the method that the vendor used for collecting their data. We hope vendors are going to be honest. We hope they're going to give us the real data, but you as the facility administrator have to also know your own data and know what's reasonable. If you get a report from the vendor that whatever data point we're talking about, it has to pass your smell test too. You have to say, wait, there's no way that they had, I don't know, that the vendor was doing intake booking screenings within 4 hours, because I've walked through my booking area and I know I've seen people sitting there for hours and hours, and I've asked the question, gee, haven't they been to the nurse yet? And the answer is no. So you have to know your facility. Again, to trust, you do have to trust some data from the vendor, but you also have to verify. Some of that is spot checking. Some of that is what I mentioned before, is looking at their methodology, and some of it is just collecting your own data.
Reggie? Okay. So Daniel asks that performance standards and expectations are different than outcomes. Are there general or specific healthcare outcomes that should be included?
Yeah, so Daniel sounds like somebody who really knows his outcomes research and terminology. And admittedly, we use those words a little bit too, maybe, I don't want to say sloppily, but the paradigm for thinking about performance is there's 3 buckets. One is structure, one is process, and one is outcomes. Structure are the things that you need to be able to conduct business. And it is brick and mortar. Do you have a building? Do you have enough physical space in the clinic to do what you need to do? But it's also about, do you have policies and procedures in place? Do you have enough staff in place? Those are all structural elements. Processes are the things that we do with those structural elements. So for example, are we screening people at intake for health conditions? That's a process. There are, however, two parts to processes. One is whether you did the thing and whether you did it on time. So did you screen people at intake, and did you do it within the time frame, let's say 4 hours? But there's a second half to that bucket of process, which is, did you do it well? It's not enough to it's important, it's necessary, but not sufficient to just say, did you do that process, but did you do it well? And I think where the confusion gets in is sometimes we label that second half of the bucket of did you do it well, we label that outcome. And Daniel, you're right in that strictly in the outcomes world, that's not an outcome. An outcome is mortality. An outcome is how often did patients with diabetes get wounds, or did they lose a limb from an amputation? And so I think when we say outcomes in this document, it's a combination of the strictly interpreted outcomes like mortality, as well as that second half of the bucket of process. Did you do the procedures clinically appropriate? If you want to check in with Daniel, if we answered that appropriately.
Yeah, Daniel, just let us know through the Q&A pod in the event that you need follow-up. So Nick is asking, should you avoid specificities in the RFPs, such as when you, the client, expect certain activities to occur? Example, avoid stating when health assessments must be done on intake, such as within 7 days, 14 days, etc., or just let the proposals determine when those things will take place? Or should you dictate certain things like that in the RFP?
Really good question, Nick. And that was also central to the work that the 6 of us have been doing, because we would ask ourselves the question, is this a standard of care? In which case we specified it in the RFP template. Or is this something where there's some wiggle room, or there's more than one way of doing this particular process, in which case what we do in the RFP template is we say exactly what you said, Nick. We ask the vendor to propose how they're going to address it. So the RFP template is a mixture of both, where there is a standard and there is no wiggle room. That's it. We've stated it that way, and where there is wiggle room, we state it. Ashley, did you? Oh, sorry. Any other comments on that?
Anyone else?
Okay. Lisa?
So Mark is asking, is it best practice to allow pricing refreshes periodically throughout contract life? Thinking in terms of market conditions, inflationary aspects, and most importantly, continued high quality of experienced staff.
I'll see if Reggie has any additional comments, but my first comment will be definitely yes. And we have woven that into this document, both in terms of how long the contract should last. So we see some contracts that are for longer periods of time, several years, and instead we opt for recommending a shorter interval so that exactly that kind of process can happen. And in addition to that, we talk about some reasons why there might be need to be pricing adjustments. And all of that under the umbrella that a lot of that depends on the pricing structure that you use for your contract. There are different structures. For example, there's 2 of the big ones are you're going to pay the vendor a set amount every month, every year, and they have to do everything within that limit. On the other hand, you have contract costing models that say, many of you know them as cost plus, which means vendors spend whatever you think you need to spend and we'll reimburse you plus handling fee plus a profit margin, whatever you want to talk about. So to answer this question properly, Nick's question, you really have to look at what option you want to choose. And in the RFP, we describe different options and explain what the pros and cons of each of those options are. Reggie, anything to?
One final question before we hand it back to Ashley. All right, so Benjamin is presenting, and I'll come back to the question. It's a little lengthy. What is the expected cost to the locality or facility of monitoring and holding vendors to performance standards? Many vendors have histories of failure to meet contractual or civil rights obligations related to provision of standards of care. As one example, standard care for opioid use disorder, such as buprenorphine therapy, which is critically important in populations in jails or prisons. These vendors may claim they will meet such obligations in a new or renewed contract, and yet often they may not, or will only do so partially. Monitoring is expensive and time-consuming. How likely is it that localities or facilities or other parties with standing will be able to succeed in holding these vendors to account based on monitoring or performance or outcome measurement? The cost to the locality or jail or prison in monitoring potentially is high, and the vendor business model appears to anticipate they will be sued and need to fend off accountability measurement or legal action holding them to contract terms. So what is the expected cost to the locality or facility of monitoring and holding vendors to performance standards?
There is a cost. Obviously, we're not, Benjamin's not looking for a dollar amount, but there is a cost, and that's where some healthcare falls flat. The quality of healthcare in contracts that the six of us have seen around the country, that you have this wonderful, perfect RFP and contract, and then you walk away from it and say, well, I'm going to go, now I'm the jail administrator. Now I'm going to go see how things are doing in the kitchen. You can't do that. You have a fiduciary responsibility to the taxpayer to monitor, and it's not free or cheap to do that. It is going to cost, and that's one of the reasons I think it doesn't get done. It's also an argument for maybe privatization is not the best model for you, because you're going to have to monitor these things anyhow, either whether you're self-operating or whether you have a vendor. Others in the group have a take on this question?
I would just add that there are, again, in the toolkit and in the template, because we had a lot of discussions about this very issue, that it's not expected that you have these two parallel siloed tracks. You have the custodial side and you have the healthcare side. As Dr. Stern is saying, it really is about bringing those two sides together so that there really shouldn't be surprises about poor healthcare, because there should be understanding from a custodial side about what's going on. So there's several different places where you'll see there's both some understanding that we don't want correctional officers doing the role of healthcare. We don't want healthcare doing the role of correctional officers, but also understanding where there's a confluence between those two systems. And that really is about making sure that the care is there and that's delivered in a way that is really going to better or help the outcomes for those who are trying to serve.
Yes, thank you, Reggie. Another thing to think about to keep your monitoring costs down is some places have the mentality that I'm going to bring in a physician. The prisoner jail administrator says, I'm going to hire a physician in our community to be my independent monitor to see how the vendor is doing. Well, that's awfully expensive because physicians are expensive. So you might think about splitting up the audits. There's some things that are very easy to audit, like, did we do an intake screening and did we do it on time? You could get a high school student to do that audit for you, but then the audit of was it done appropriately, that little part of the audit you would give to the more expensive monitor.
So we do have a response from Daniel as it relates to his performance measurement outcome question. He is letting you know, Dr. Sand, that you were very helpful and well articulated in your response. Very generally, his belief is that there needs to be culture from the institution and vendor that their job is to make the patient well. Outcomes should fit that culture. I think that's a great place to stop. All right.
Thank you all. Thanks, Lisa, for controlling that flow. So we're going to show you exactly what this looks like. We've been promising that and talking a lot about what is in here and what we've covered, but we're going to give you a glimpse in our last few minutes, and then I'll share a slide that has the actual link and easy access code on there. So this is the toolkit. You've seen the RFP template, that Word doc already, but this is the website where we house the toolkit. So the larger sort of background and how to use that RFP template. I won't go through much of this in detail, but you'll have sort of headers on the left that each have different sections and different content in here. You'll have a lot of the items, or all of the items that Dr. Stern mentioned, as well as others in, even kind of pre-RFP and in thinking about your model very intentionally. And you'll have some content here that can be expanded. So this is really user-friendly. And then the two main sections that you'll need are these download buttons. So the RFP template, again, that Word doc is this red download button. It's on all of these pages. It'll show up. And then if you don't want to scan through the website, if you prefer it more in a written one scroll format, you can download all the contents of this toolkit, the website, through the black button here. So we've given it to you in two formats. You can also, if you click that download the RFP template button, it'll take you to the bottom of the screen, whereas there we have a quick form asking for a little bit of information to download that Word document. And so that, again, very easy to use. We'll show you how to, the link to access in just a moment, but so you all know what our vision is past today. A lot of the effort was getting us to today, but we really plan for this to be a living, working document. So we have pretty constantly been making updates to the RFP template, in particular when there was something new to be included, when we received feedback from our large group of reviewers. As recently as this week, we've tweaked some things in there. So we welcome feedback from all of you, especially as local sites start to use this. And if you have questions, if you have pieces that you think should be added, changed, please let us know. We'll have our contact information up on the screen. We also plan to do some research, ideally, and some evaluation on its use. So that's part of the reason we asked for a little bit of information ahead of download. Again, we will not be bombarding you with updates or emails or anything like that, but we really want this to continue to be as useful as possible. If you are from a community that is looking for more hands-on technical assistance in implementing the toolkit and using the template, please again reach out to us. We do have some capacity to do that. So here is the promised link. So you can either point your phone at the QR code on the left. To the right is the actual link to access that toolkit page, or you can go to Policy Research Associates homepage, prainc.com. It's in our resource library that's circled in yellow. So there are multiple ways you can access this. And you will also have the link emailed out to all of you who registered for the webinar today. So you don't have to grab this quickly before we move on. But if you want to, it's there. And again, we welcome any and all feedback in implementing this across your communities. We'll do a final check for any additional questions in our last minute or two, but otherwise, here's some contact information, especially for Dr. Stern and myself in particular, also our company. So reach out, please, with any questions or pieces of feedback. Lisa, any other questions we want to try and grab?
Not a question, but a comment from Kenneth. He's making the statement that having done both proactive risk management monitoring and federal court monitoring, proactive risk management monitoring is far less expensive.
The great summary point to end on, I think, one we'd all agree with. Well, thanks everyone for your time. We will email out the link and resources, and we appreciate your feedback very much.